So we've heard a lot about endoscopy so far. It's time to sort of take a different tack on things, and so to sort of give us our next lecture entitled Acute and Chronic Pancreatitis, a surgeon's perspective, it's my honor to introduce Joe Hines, our professor of medicine at UCLA. He's also director of the general surgery program. He's also director of the surgical residency program, and he's, as Rabindra just alluded to, he's part of our a really superb collection of surgeons who are part of our Center for Pancreatic Disease. So, Joe, thank you.
Thank you, Raman. It's a pleasure to be here this morning and have the chance to talk a little bit about surgery. I was having breakfast this morning with one of my colleagues, and he said, well, what are you going to talk about? Just cut it out? And I said, well, actually, there's less and less of that in this disease as we move forward. But surgery still is an important part of the management of both of these diseases. I'm going to just flip through some thoughts about where we fit in and some important background as to how we think about managing both acute and chronic pancreatitis. I'm not going to spend much time talking about mild or moderate acute pancreatitis. The management of that is pretty straightforward. I spend a little bit more time talking about severe acute pancreatitis and how we think about that and the complications of pancreatitis. And I think the summary recommendations from the International Association of Pancreatology is really very useful when we think about how we treat acute pancreatitis. I'm just going to go through these because I think they're really the main points of this part of my talk. So mild acute pancreatitis is not an indication for pancreatic surgery. Seems pretty straightforward. When patients have more advanced severe pancreatitis with necrosis, which has been identified on CT scan, prophylactic antibiotics appears to reduce infection rates, not only of the necrotic material, but also all infection rates in patients who are severely ill and in the ICU. When you're concerned about infection in necrotic pancreas, an FNA and gram stain and culture is important to be able to demonstrate that this is in case the fact, because we now manage sterile pancreatic necrosis in a different way than we do infected pancreatic necrosis. In patients who have infected pancreatic necrosis and signs of sepsis, intervention is required, and that is to debride this material either surgically, radiologically, and now work being done endoscopically. Generally speaking, we do not debride sterile pancreatic necrosis, and this is something that's new really over the last 15 to 20 years. There are groups of patients who have sterile necrosis that we do need to take to the operating room. These are patients who really have failure to progress. They really didn't get that sick maybe after the episode, or they have recovered, but they're 2, 3, 4, 5 months out from the initial episode, and they're just not progressing. And we do debride these patients after really they've fully recovered from their disease, but they're still having some issues. Early surgery within the first 14 days after the initial episode of acute pancreatitis is probably not a great idea, but there are clear indications for some patients who have necrotizing pancreatitis. For instance, you can have gangrenous cholecystitis, or part of your colon can die, or the patient may have intra-abdominal compartment syndrome that needs to be relieved. So there are indications to take patients to the operating room early on, but it's generally not to debride the pancreas. The surgical and other forms of interventional management should favor an organ-preserving approach, so we just basically take out all the bad stuff and leave the good stuff behind. A cholecystectomy should be before to avoid the recurrence of gallstone-associated pancreatitis, and the timing of that is variable. So for mild acute pancreatitis, that's generally on the admission, because the recurrence rate is fairly high when you discharge those patients and they don't get back to under our care. For patients who have severe gallstone-associated acute pancreatitis, really all the issues with the pancreatitis should resolve before we think about doing the cholecystectomy. And for a certain population who are elderly or not good risk for the operating room, endoscopic sphincterotomy is an alternative to cholecystectomy. So I think those are all great important points. But now I want to focus purely just on severe acute pancreatitis. And it's really a minority of patients that have this. Necrotizing pancreatitis is a very serious situation. Mortality rate remains relatively high. and especially bad when it becomes infected. And the likelihood of infection correlates with the amount of necrosis. So when a patient presents with systemic signs of a systemic inflammatory response, they're not acting right, these are the patients that really we have to pay much more attention to. We all know about the staging criteria that we can use to try to categorize patients into severe a form of pancreatitis that requires more immediate attention, maybe moving to the ICU. This is a really great image I like to show of a patient that I took care of with the GI colleagues at UCLA who had recurrent pancreatitis, and one time an episode of very severe pancreatitis. If you see, this is an MRCP, and this is the sweep of the duodenum. Here's the pancreatic duct, the common duct, right and left hepatic ducts. And this patient actually had a main duct IPMN in the tail of his pancreas, and he was having recurrent episodes of pancreatitis. And this resulted in the formation of this pseudocyst, the other cystic lesion that you can see in the head there. And so ultimately this patient had distal pancreatectomy to address the main duct IPMN, and then endoscopically had the pseudocyst drained by gastroenterology. So really interesting a patient and great images. Patients who have sterile pancreatic necrosis generally, again, like I said, non-operative management is the key, just supportive therapy. Monitor them to make sure that they're not getting an infection, and operate only if there are complications early on. The questions with regards to infected pancreatic necrosis is really how aggressive do we need to be? Traditionally, this has been a big operation. We always knew that the patients, when we took them to the operating room, would get much sicker. After the operation, required ICU stay, oftentimes pressors, really intensive support. But there's a lot of shift in the way that we treat these patients, and surprisingly, it doesn't always require that we actually debride the infected material. So this is a sort of traditional approach. We would take them to the operating room, do an exploratory laparotomy, make an incision in the transverse mesocolon. The reason we do that is because there's not a lot of vasculature on the left side of the transverse mesocolon. We're able to access the lesser sac and the pancreas and debride the pancreas through this area. And this is a photo, an intraoperative photo of that shows, you're looking, this is the head of the patient up here, this is the ribs on the left side, this is looking sort of towards the left side, this is the transverse colon, and the mesocolon is sort of green, discolored area. We would approach the lesser sac through this area and remove the pancreas. And you know, this is, as a surgeon, somewhat of a gratifying operation because you're really sort of cleaning up a lot of mess, you know, draining pus and getting rid of bad stuff. It's fun. Sometimes you reach in there and you actually pull out the entire gland, and this is actually the entire pancreas, which was necrotic, that we pulled out, so it's almost a complete pancreatectomy when we did this operation. But there's a big evolution over the last 10 to 15 years on how we treat these patients, becoming less invasive. These patients, if you can be less invasive, have a lot less systemic inflammatory response postoperatively. And the movement for this really started in Glasgow. A guy, Ross Carter in Glasgow, first published work where he was treating these patients with percutaneous approaches, placing a pigtail catheter there and upsizing this, and ultimately using a nephroscope to debride the material. And I had a chance to visit him a few years ago. They have a huge ward with a large number of patients with severe complications of pancreatitis, and they're very progressive. And the patients surprisingly do quite well. This really began to change the way we think about pancreatic necrosis. A couple years later, a work out of Heidelberg, a large group there, surgeons that take care of pancreatic patients, published their series which showed that in their experience they were taking patients to the operating room less, and when they took them to the operating room less, the mortality rate was lower, at least pushing the surgery out further than from when they first presented to the hospital. Then came along this idea of a step-up approach. A lot of the information that we are now using to manage patients come out of the Dutch Pancreatitis Study Group, and they've done a lot of fantastic work with us. The Panther trial, which was published in 2010, where they randomized patients with infected pancreatic necrosis between open traditional necrosectomy and then percutaneous drainage with a minimally invasive necrosectomy. And the patients had less complications. They had fewer multi-organ system failures, less issues with surgery, obviously less incisions and new onset diabetes. But amazingly, from this study, which I think is a huge take-home point, is a third of the patients with infected pancreatic necrosis, all that they needed was a drain. They actually didn't need to have the material debrided. So this really changed the way we began to manage these patients using so-called step-up approach. And now they've just recently published their early experience with the Penguin trial, the pancreatitis endoscopic transgastric and primary necrosectomy in patients with infected pancreatic necrosis trial, where they're doing this transgastrically, transorally. This was a very early report, and there's more to come. There are patients who, with chronic and acute pancreatitis who obviously have complications. There's already been some discussion of that. Pseudocyst management, pancreatic abscesses, ascites, and hemorrhagic pancreatitis. These all potentially involve surgical management. This is a great pseudocyst that would be, we would probably have a GI drain transgastrically. Generally speaking, if there's no necrotic material, it's a pure pseudocyst, we've felt very comfortable with having GI just orally drain these, and that's probably how most of these are being addressed. There's some that we still need to take to the operating room. This is an algorithm and a little bit complex. It's in your book. But generally speaking, patients with acute pancreatitis, ultimately most of those patients who have pseudocysts are managed endoscopically at our place. Patients who have chronic pancreatitis are more likely to go to the operating room ultimately for their drainage procedures, because oftentimes this involves a main pancreatic duct disruption, and maybe that surgical diversion is a better approach for those patients. And obviously, if there's an infection or infected pancreatic pseudocyst, all you have to do is percutaneously drain those. Patients who have hemorrhagic pancreatitis generally should not go to the operating room because it is a disaster when we get there. There's all this necrosis. The bleedings, we're not quite sure where it's coming from. We make more bleeding. These patients should be in interventional radiology. This is a patient who actually just had a splenic artery aneurysm that was coiled, and that usually works quite well. So I'm going to switch now to chronic pancreatitis and go over some details about how we evaluate these patients, how we think about them, and largely where it is we get involved. Obviously, a lot of patients with this problem in the country. Mostly these patients ultimately go on to die of their comorbid conditions. They oftentimes are smokers. They have severe coronary artery disease, sometimes cirrhosis associated with their chronic pancreatitis, but they do present with complications of their chronic pancreatitis that require treatment. When we see patients, largely we operate in patients with chronic pancreatitis for pain. That is the most single common indication, and so we're spending a lot of time learning about how long the pain has been there, how they're treating it, and if we're certain that actually the pain is caused by chronic pancreatitis. We see so many times patients who come to see us who've been given the diagnosis of chronic pancreatitis, but in fact they do not have chronic pancreatitis. They have other etiologies for their chronic pain, and so we do a lot of work to try to get some information to demonstrate that yes, they do have morphologic changes in their pancreas or ductal anatomy, or maybe even by EUS just to determine the signs of inflammation on the pancreas to be certain that yes, they actually do have chronic pancreatitis. Indications for surgical intervention in patients who have the disease would, of course, be pain. Some patients who have pseudocysts, we already talked about, sometimes a pseudoaneurysm, and then the discussion that was held earlier, sometimes issues with whether or not there's a malignancy, especially with patients who have chronic pancreatitis that is isolated to the head of the pancreas. Sometimes it's really hard to know if those patients, when they present with biliary obstruction and pancreatic duct obstruction with a mass in the head, these patients obviously have an increased risk of formation of pancreatic cancer, and it's difficult to know by imaging, even sometimes by biopsy, if they actually have an underlying malignancy as a source of their problems. So we try to see, is the pain interfering with their life, assess how much pain medicine they're using. Almost all these patients are already on chronic narcotics, addicted to narcotics when they come to see us. That's not a contraindication to go to the operating room, but we just want to understand the extent of it before we take them to the operating room. If we have a patient comes to us with chronic pancreatitis secondary to alcohol use, alcoholism, they would need to address that certainly before they went to the operating room, before we would entertain the idea of doing this. We look for calcifications in the duct. We look for changes in ductal anatomy on the MRI, EUS sometimes. And this was discussed already by Ali, but I just want to put a pitch in that this is actually the best data we have. This is level 1 randomized data, which shows that in this, again, not large trial, 38 patients, as he pointed out, 32% of them didn't require any other treatment after endoscopic management, and most of the patients who were on the surgical arm didn't require any treatment for pain after having gone to the operating room. One patient required a reoperation, additional pancreatic resection. Small study. I agree with Ali that these patients really need tailored therapy, but this is the status of the data that we have at this time. When we look at a patient with chronic pancreatitis, we're looking at the ductal anatomy, and we make decisions about what type of operation we would do based on whether they have a dilated duct or a small duct. And generally speaking, patients who have large ducts are male patients, oftentimes associated with alcoholic pancreatitis. They have ductal calcifications, oftentimes have steatorrhea and other manifestations of their chronic pancreatitis. And surgery helps these patients. Patients who have small ducts are more likely to be women. An etiology of their pancreatitis not particularly clear. And so it's hard for us to figure out always how to help these patients because the outcome from surgery is less advantageous than in patients who have large duct disease. So if you have dilated main duct, calcifications, clear diagnosis of chronic pancreatitis, generally speaking, there's a drainage procedure or Roux-en-Y pancreaticojejunostomy, and that can be a Pusteau or a modified Pusteau called a Fry operation, which I'll show you a picture of. If they have disease that's located in the head, then we focus on the head with a Whipple resection or another operation that's much more common in Europe, something called a Beggar operation, which is a duodenal preserving pancreatic head resection. And if they have left-sided disease only, then we would obviously just address the left side. That's not common. So this is what a pancreaticojejunostomy or a Pusteau operation looks like, where you just simply fillet the pancreatic duct and then do a side-to-side anastomosis between roux limb, and that allows drainage. Generally speaking, Pusteau, the outcome for Pusteau is not as good as something called a Fry operation. Dr. Charlie Fry was at UCSD and a friend of many of ours. He developed an operation where the head of the pancreas is cored out, and this is contiguous with a filleted open main pancreatic duct. And this is an intraoperative photo showing this is the head of the pancreas, this is the duodenal sweep, this is what's been cored. This is a Red Robinson tube that's put into the main pancreatic duct and the minor pancreatic duct here. And then these sutures here are along the edges of the filleted open duct. You can probably see that better on in your manual. But then we just sew a roux up to this. And this is more effective at pain relief than just simply a Pusteau or a lateral pancreaticojejunostomy. This is a Beggar operation. It's a little bit more than a Fry. So we actually take the whole head of the pancreas out here, and we leave a little rim of pancreas here, and then we bring a roux limb that comes up and sew to the body tail of the pancreas, and then along this rim of pancreas that's near the duodenum. Has very good outcomes and is not done, though, commonly in the United States. This is a meta-analysis of pain outcomes for patients who enter either a Whipple operation or a Fry procedure. PD stands for pancreaticojejunostomy. So pain-free patients, 82% for the Beggar operation, 72% for a pancreaticojejunostomy. Overall, pretty good outcomes. This is what we would do commonly if the disease was located in the head, and that's just simply a Whipple operation. And probably a Whipple operation has about an 80% 5-year pain-free outcome overall. This is an analysis of our patients. We, over this time period, had operated on about 80 patients and did a quality of life survey looking at all sorts of things like cognition, emotional status, pain. This was a 99-month median follow-up, so fairly far out. And really very good results. So generally speaking, for surgery, we always tell patients that they can expect 75% of them will expect pain relief by going to the operating room if properly selected. Sometimes we do a total pancreatectomy for patients who have chronic pancreatitis, and we have had a recent experience with this with auto islet transplantation to try to preserve their insulin function. Generally, this procedure is reserved for patients who have failed prior operations, patients who had hereditary syndromes, PRSS1 or Sphinx mutations, or patients who have evidence of recurrent pancreatitis and chronic pancreatitis, but we're also worried about the potential for them to form pancreatic cancer in the future, and we've ruled out that that's going on right now. We would perform a total pancreatectomy for these patients with islet cell transplantation, and then these patients who have small duct disease where these drainage procedures probably don't work quite as well. We've done in the last 2.5 years 9 patients, total pancreatectomies with auto islet transplants. We do not have an islet isolation center at UCLA, but there is one at UCSF. So the way this works, we take the patient to the operating room, we do the total pancreatectomy and complete the reconstruction, and a separate team takes the organ to UCSF. UCSF has an islet cell isolation, so they fly out of Van Nuys, go up to San Francisco, isolate the islets, and during that period, which takes about 3 to 4 hours for them to turn around, the patient actually stays in the operating room on the table, sewn up, and then they come back and do a portal vein injection. And so the patient is in the operating room for 8 to 9 hours. And over the last 2 years, we've done 9 patients. Patients who actually had a total pancreatectomy, 3 patients were able to come off insulin or are currently weaning off. 3 patients are still requiring some insulin. And then the patients who had a Whipple followed by an islet cell transplantation, 2 patients never required insulin, and 1 patient we're not sure what happened to them. We haven't been able to get follow-up. So it's one thing to consider for patients if they're concerned about if they don't have yet diabetes, to try to alleviate that. This is especially a good consideration in young patients who had hereditary pancreatitis. Rabindra already mentioned this. We have a large group. We meet every Thursday morning at 7:30, and I would invite anyone who has an interesting case locally or wants us to review the films. We have 15 or 20 providers at each of these meetings, a large list. We're happy to give you a remote consultation or those sorts of things. It's really a passion for us at UCLA, and I appreciate the chance to speak with you this morning.